I'd like to apologize about my delay. I had a terrible traffic, actually. First of all, I would like to thank the organizing committee for inviting me to present this talk about the treatment approach in refractory and relapsed chronic lymphatic leukemia. And I think my colleague, Professor Hala, Professor Mervat, covered the important topic, and they will make my job easy. There is no doubt that the roadmap of treatment of chronic lymphatic leukemia in the last few years has been changed in the era of in the era of availability of multiple novel agents. The disease is actually represent around 20,000 estimated new case in 2019 in the United States, and the median age at the diagnosis around 70 years. It's considered that the most common type of leukemia in adults. With this novel agent, the 5-year free survival improved to 6%, and the current 5-year survival is around now 85. This is a typical course of chronic lymphatic leukemia when the patient is there's indication for treatment. The patient started treatment till patient achieved a complete remission, and after that, the period from achieving complete remission till the disease progression, this is called the progression-free survival, and the duration from the achievement of complete remission till this is the overall survival. And after achievement of the remission, the patients may develop the disease again, but it is not important to restart the treatment until there is criteria to start treatment again according to the international workshop of CLL. This is the development of the medications of CLL since 1960 till now. And as you can see in the last decade, there is a development of different agents, novel agents, and used in the treatment of CLL, like the BTK inhibitor. It's the B cell signaling inhibitors like ibrutinib, and the new second generation of CD20, like pontezumab, and the ofatumumab, and also the BCL2 inhibitor, the drug called venetoclax. This is the dangerous triple pathway that responsible about the pathogenesis of the disease. There is a pathway for the B cell signaling, and it's blocked by ibrutinib, and the other pathway, the BCL2, and blocked by the anti-BCL2, the venetoclax, and the other one is the pathway of the PI3K, and is blocked by drug called idelalisib. So this mechanism of actions leads to increase the proliferation of the B cells and stimulations of the growth and proliferation. So the treatment of relapsed refractory CLL, there is a lot of consideration when we decide to start treatment for relapsed CLL. Number one is the performance status and the age of the patients, and the availability of the novel agents, and also considering the long-term toxicity of the drug, the patient adherence, and the finance, of course. Here we will discuss the RESONATE study. RESONATE at comparing, I think Professor Mervat talked about it in the front line, and actually Provica is the only single agent that can be used widely as a front line and also as a second line. And this study, sorry for this. There's some missing slide actually. Anyway, in this study, they compare between the Improvica and ofatumumab, and the primary endpoint was the progression-free survival. And the majority of patients had CLL in advanced stage, and 5% of them had small lymphocytic leukemia. The median number of therapy, 3 for Improvica line versus 2 for ofatumumab, and the majority of patients had received previous treatment with purine analog, alkylating agent, and anti-CD20 monoclonal antibody. And across the treatment group, 31% had the 11q deletion, and 23% had the 17p deletion. And most patients in Improvica group has a bulky disease in comparing with the ofatumumab. ده diagram missed كان اللي هو visual comparison between two arms. And this is the curve for the progression-free survival, and this is the overall survival. Also, the diarrhea and atrial fibrillation was frequently seen in Improvica. I think this common side effect of atrial fibrillations and GIT toxicity was discussed with Professor Mervet. Also, the bleeding-related adverse effects of any grade were more common in the Improvica group than in the ofatumumab group. At 16 months follow-up, over the 16 months follow-up, the most frequently reported adverse events were diarrhea, fatigue, cytopenia, constipation, and pneumonia, and most adverse events were grade 1 in severity, and most bleeding events occurred within the first 3 to 6 months of Improvica treatment, and the major bleeding events occur in 1% of patients versus 2% in ofatumumab arm, and despite 50% of Improvica treated patients receiving anticoagulation and antiplatelet therapy. Atrial fibrillation of any grade occurred in 13, around 70% of Improvica treated patients, including 3 additional patients reported since interim analysis. This is the 16 months progression-free survival, and you can see there is the progression-free survival in the Improvica arm. This is the upper arm is not reached after 16 months, while in ofatumumab it became 8.5 months. And this is the safety profile also after 16 months. As you can see that the most common side effect is the diarrhea, atrial fibrillation, and the percentage of developing grade 3 to 4 toxicity are very minimal with Improvica. About the final analysis after 6 years update of Resonate 1, also this still the progression-free survival with a median 3 prior line of treatment of the CLL patients was 44 months versus 8 months with ofatumumab. So the patient achieved after 6 years with Improvica arm around 44 months, comparing with 8 months in ofatumumab arm. Also the progression-free survival, there's a benefit from the early use of Improvica comparing with late use, and there's overall improvement in overall survival in the Improvica arm, especially if it will be used early. And in all risk group, there is, especially in the high risk group based on cytogenetics and other markers, Improvica show better overall survival comparing with ofatumumab. So the median overall survival was 6 months in the Improvica arm, And overall survival after crossover was better with Improvica than ofatumumab. Safety profile with up to 71 months on Improvica therapy, and safety profile remained constant with prior report only 16% discontinue due to adverse event. Sequencing and responses of the next line treatment, example with venetoclax, adalimumab, rituximab, following Improvica discontinued were observed in 10 from 27 patients in this group of heavily pretreated patients. This is another study actually addressing the incorporation of Improvica with other agents like brentuximab, bendamustine, and rituximab, with comparing with bendamustine and rituximab alone combined with placebo. And also the primary endpoint was the progression-free survival in this study. And as you can see, the Improvica arm with bendamustine and rituximab showed better progression-free survival, and no transformation to the more active form like pressure transformation were absorbed in the Improvica arm, and three was absorbed in the placebo arm. Also here, the median progression-free survival does not reach in 13 months, while it was in placebo arm was 13 months. Here the overall survival results are confounded by crossover to receive single agent Improvica. Overall Improvica reduced the risk of death by 37%. So the arm containing Improvica is superior in the term of progression-free survival and overall survival. Also in the MRD negativity, which is very important topic in the treatment of CLL and different hematologic malignancies, the achievement of the MRD negativity with Improvica plus BR was superior or better in comparing with the placebo plus BR. Here the safety profile, the used Improvica as a monotherapy was not different match with using a combination, apart from increased incidence of neutropenia and infection related problem. Also, there was some cases reported bleeding, but the grade 3 or 4 toxicity was actually, the percentage was minimal. And here also the most common adverse event was febrile neutropenia, pneumonia, and atrial fibrillation in some patients. And tumor lysis syndrome was high a bit with the arm Improvica and BR. How about the final 5-year update from these results? Here we can see that the median progression-free survival of the Improvica arm at final analysis was 66 months, which was significantly longer than the median progression-free survival for patients with a placebo arm, which was 14 months. And the overall survival advantage for patients in Improvica arm compared with this in placebo arm, the 60 months overall survival rate was 75% for Improvica, while it was 60 for placebo arm. Also, the MRD negativity was actually observed in the first 3 years. The complete response rate was plateaued at the 3 years follow-up analysis, and the collection of the data in MRD was terminated shortly afterward. The proportion of patients with undetectable MRD in peripheral blood did not notably change as the final analysis compared with published 3 years analysis. Also, the toxicity profile after follow-up for 6 years, the more than grade 3 adverse event was around 90% in the Improvica arm, And actually the related the side effects were a bit comparable, and the discontinuation of the treatment was around 20% in the Improvica arm. The conclusion from this study, the extended follow-up data with a median of more than 5 years, confirmed that the addition of Improvica to BR resulted in long-lasting response that deepened overall over time, and Improvica significantly improved median progression-free survival. There was an overall survival benefit with Improvica compared with placebo, despite the crossover from placebo to the Improvica arm upon disease progression. The progression-free survival benefit was maintained with extended follow-up, and the overall survival advantage with Improvica was significant, both at the 3 years analysis and this final 5-year analysis. The safety findings were consistent with the known safety profile of Improvica and the bendamustine rituximab arm. Actually, and I will end by the last version of the NCN guidelines, which actually stressed upon the treatment of the relapsed refractory patient with CLL for those who are more than younger patients than 65 years. The preferred regimen was category A. Improvica was the considered in this group. Also, venetoclax rituximab was category A. Nivolumab is a new agents, and idelalisib rituximab. Also, in the elderly patient without comorbidity, epitinib was category 1. Acalabrutinib was category 1, 2. Venetoclax rituximab and nivolumab, idelalisib. All of these combinations are considered in the both young, fit, and elderly patients. Thank you very much.
Thank you very much, General Dr. Mahmoud Salah, for his nice presentation. And any question from Dr. Mahmoud?
May I ask one question?
Okay, yes.
General Dr. Mahmoud Salah, what do you think the future will be in relapsed refractory chronic lymphocytic leukemia the next 3 years?
Okay, if we are talking about the availability of all agents and we'll forget about money, so I think these patients will get benefit from the chemotherapy-free protocols. The combination of novel treatment like Improvica plus venetoclax plus opentizumab, we will block the triple pathway leads to pathogenesis of the CLL. So, and I think there is some trial about that, phase 1 and phase 2, and the response rate is very high. The achievement of the minimal residual disease negativity in the bone marrow is higher. So I think in the next future there will be a strong and optimal solution for the refractory cases of CLL.
So probably we'll reach the CML phase of treatment-free remission?
This is very difficult because, you know, the biology of CLL is completely different than the CML. The CLL is a chronic disease and needs to have a continuous treatment to keeping the disease on remission all the time. So maybe there is some trials now for limited period of treatment, because, you know, from the other resonates there was some side effect from the long-term use of the drug, like the cumulative toxicities, adherence of the patients, financial toxicity. So the trend now is to use the novel combinations, aiming to limit the period of treatment.
Thank you, sir.
Okay.
Thank you.
I think, Dr. Mahmoud, the future frontline therapy right now for CLL patients is a combination of novel agents. I think there are two famous clinical trials. They are in phase 3 right now. I think will be maybe reported in this year. One combination is Venetoclax plus Ambrivica.
Yes.
Yes, and second combination is Venetoclax plus rituximab. I think we are going to achieve two goals here. The first goal is to achieve a limited time of treatment for this patient, and second goal is to get MRD negativity. I think this year or next year will carry a good news for CLL patients. But the problem is the money.
Yeah, this is absolutely right. If you forget the money, so you have a lot of options to help your patients. And actually, these two studies are very promising. And but I didn't mention because they didn't approve yet.
Yeah. Thank you very much, Mahmoud. Any question to Dr. Mahmoud? Okay, right now we are going to close the session. Thank you very much.